Okay. Um, when we start talking about real registration, I thought that there is often some confusion because we have IAP, which does a fantastic job of conducting the basic registration program. And then we have the NNF and IAP itself doing the advanced registration program. So very often there is a bit of confusion among us. So I thought that it's my duty to kind of clarify the difference and the importance of where each of them has a role, and I'm trying to identify and clarify this role. So when we start with the program itself, I mean neonatal registration, let's look at a simple number. Let's say that I'm going to resuscitate about 2,000 babies. How many of them really would need any kind of resuscitation? So that's what my question. The question to answer. Most of them, about 1,700 of them, would start breathing by themselves. So they are our breadwinners because no, we don't do anything except drying and mopping them, and then they still give us money in our pocket. So we are happy about it. And there are some more, about 200, who would need not more than just they just can't take care of themselves. So we need to dry them, stimulate them, and then they will start breathing. But out of those 200, about 100, that's about 5% of them would need positive pressure ventilation. That's looking at it. I mean, that's about 5%. Okay. And less than 40 of them would need alternate airways. And please remember, these include all the preterm babies, all the high-risk babies, or your IUGR babies. So in day-to-day life, when particularly in peripheries, if you look at it, the number of babies needing alternate airways like intubation or a laryngeal mask airway is very, very small. And those who need cardiac compression is essentially 2. So 2 out of 1,000 or 2 out of 2,000 or 1 out of 1,000. And if you think of giving vascular access and needing vascular access and giving adrenaline or normal saline, then the numbers is even less, just 1 out of 2,000. So in average unit, I mean, even if you're delivering one baby per day, so to see a baby needing cardiac compressions, it will essentially need us about anything between 7 to 8 years. So once in 7 to 8 years. And if you think about this, so a lot of skills which we used to learn in neonatal registration, particularly, I mean, we got a lot of it from the American Academy of Pediatrics, their neonatal registration. So we used to concentrate, we get very excited with the advanced, with intubation and cardiac compression. But as you could look at those numbers, they're really not necessary in most scenarios. So the IAP, along with the government of India, came up with this program, and this program has been run very effectively and free of cost by the Indian Academy of Pediatrics to train all people, just not doctors, anybody who is involved in neonatal care. So essentially, we have got basics. In other words, though it is basic, ideally, I think the better word is actually essential neonatal resuscitation. That's the word which is used by American Academy of Pediatrics, and I think we probably are better off using it. And then we have got the advanced NRP. So the basic, this is decided only by the availability of resources and what kind of babies which we are going to handle. So if you look at it, most of these deliveries in our country happen in a PHC. We will be very lucky to have a delivery room like this, a warmer and enough space to resuscitate. More often than not, we get thrown out as pediatricians, and then babies are just handed over to us after the baby is born. I mean, not even in the same room. Of course, in places which have got all the kind of high-end facilities, you've got the monitors, you've got your infusion pumps and whatnot. I mean, you've got your CPAPs, and in the delivery room, yes, definitely advanced NRP has got a relevance. So where is basic NRP relevant? First, when we think that the newborn does not have any significant risk factor, that could be either perinatal for the mother from the maternal point of view or from the newborn point of view. And second and most important is that if the baby is going to be born at a site and we are going to continue to care for the baby, if you think this baby is going to need the transfer after delivery being born, you are better off referring the baby to a place where they could handle those babies. Okay, so basically we are talking about smaller hospitals, clinics, and PHCs and those kind of stuff. So, and what equipment we will need? This will be gone in detail with the basic NRP program, discussion. But pretty much you need a resuscitation area, preferably with a warmer. You need a suction. Again, lucky to have an electrical operated one. Definitely we need oxygen and an amber bag. Last but not the least, you should have an ambulance. So if you get into trouble, you should be willing to transfer to the nearest healthcare facility with no delay. So we should, and that's what it is. And how many people do we need? Basically, we need one trained person. That could be a physician, it could be a nurse, registered nurse, it could be a DAI, it could be a nursing assistant, anybody who is going to handle the baby soon after delivery. And of course, we need a helper. One person cannot do everything, so we need a helper. And again, that helper need not be somebody who is highly educated. It could be an ordinary person. Advanced NRP is all about high-risk newborn care. Okay, so essentially, it's more restricted to larger hospitals and teaching hospitals. Equipment-wise, apart from basic NRP, we need a pulse oximeter. And now with the changes happening, we need a ECG monitor also. Definitely a blender. We should have capabilities for intubation or use of laryngeal mask airway, preferably a CPAP, and facilities to do a vascular access. And look at the difference. I mean, we need 4 to 5 trained persons, a team leader, an assistant provider who can take care of the airway, another one who can take care of the circulation, a helper, and last but not the least, a scribe who actually documents everything as it goes. I mean, in a stressful scenario like resuscitation, neural resuscitation, time does fly away, and we often forget the details too, and that often gets us into the lot of medical legal muddle. So, just to run through the process, again, to be talked in detail. So basic NRP is all about temperature, airway, breathing, and because please remember, it's only about you. I'm the only person available, so you cannot jump between airway and circulation trying to give cardiac compression. So either you wait for help, or if not, try to take the baby and run to the nearest facility where we can continue with the resuscitation and beyond. That is, advanced NRP is about everything from temperature, airway, breathing, circulation, and of course, vascular access and drugs. Now, let me just complete by saying that how often we should train. Most of us feel that we have trained once, we are happy, but please remember that if we don't use our skills, and we often tend to forget. And so, according to the American Academy of Pediatrics, the recertification should be done every 2 years. That means all of us should train every 2 years. So, and luckily for us, the Indian Academy of Pediatrics is offering free training of basic NRP in every place, and I request every individual branches to if you are from Pondicherry, of course, I am the state academic coordinator, and if you are Chennai, it is Dr. Prakash, who is the state academic coordinator. I mean, from Tamil Nadu, it is Dr. Prakash, who is the state academic coordinator. We will be more than happy to organize basic NRP programs in all over Tamil Nadu and Pondicherry with the aim of training a lot more people. Thank you very much. Thank you, sir.
Thank you, Dr. Thiru. So you have NRP essential for anyone involved in the care of newborn, and you have advanced NRP, which is beyond the positive pressure ventilation. Now we go on to the next topic by none other than our local neonatologist, Dr. R. Balakrishnan, KMCH, to talk on the gist of basic NRP. Over to Dr. Balki. Dr. Balakrishnan?
Yes, sir. Am I audible, sir?
Yeah. Please stick on to the time. You are allotted 25 minutes from now.
Yeah, sure, sir. So good afternoon, everybody. At the outset, I would like to thank IAP TNSC for giving me this opportunity to be part of this wonderful CME on neonatology. So my topic for today is the gist of basic NRP, or as rightly pointed out by Thirumurugan sir, it's the essential NRP. So my outline of my talk would be, I'd be dealing on transition at birth, the need for resuscitation, how to prepare for resuscitation, and what are the various steps of resuscitation up till the bag and mask ventilation or the positive pressure ventilation and the ventilatory corrective steps. Following which, Dr. Uma Maheshwari from SRMC, she will be talking on intubation, chest compression, and medications. So one of the most complex physiological adaptation in the entire human life is the transition that happens at birth. So this is the fetal circulation. As you can see here, the oxygenated blood from the placenta goes to the heart, and from the heart to the systemic circulation. And the amount of blood that goes to the lung is less than 10% of the cardiac output. So majority of the blood goes to the systemic circulation. And what happens soon after birth? The lungs, which are fluid filled, change to an air filled organ. As we clamp the umbilical cord, the systemic resistance increases. And as the lung expands, the pulmonary vasodilatation happens, and there is increased pulmonary blood flow, which helps in oxygenation and ventilation. And subsequently, the foramen ovale and ductus arteriosus close. So what can go wrong during this transition? The lungs may not be filled with air, which will result in inadequate ventilation and oxygenation. As you can see here, the lung fluid should go out and the air should replace. And foreign materials such as meconium may block the air from entering the alveoli. And a failure of lung expansion may cause persistent constriction of the pulmonary arterioles, resulting in pulmonary hypertension. And because of hypoxia and ischemia, it can result in hypotension. So hypoxic ischemic insult can cause multi-organ dysfunction involving all the organ systems, especially the CNS, which can result in both short-term and long-term mortality and morbidity. So the aim of resuscitation is to facilitate this transition in the neonate so that we can prevent hypoxia and ischemia in our neonate. So this is a pyramid approach in neonatal resuscitation. As pointed out by Dr. Thiru sir, all the babies require immediate assessment at birth and just simple newborn care. Only about 5 to 10% of the babies require simple stimulation to help them breathe, like drying and rubbing. About 3 to 6% may need basic resuscitation in the form of bag and mask ventilation and positive pressure ventilation. And less than 1% need advanced resuscitation. So this is to emphasize the point that most of the babies would need basic resuscitation. And at least one provider who is competent enough to provide positive pressure ventilation should be present at the time of delivery of all the newborns. So a job well started is half done. So preparation at birth is key. So anticipation helps us to be prepared better for the resuscitation. So how to be anticipated? So we need to ask 4 questions as we enter the delivery room or the theater. What is the gestational age? Is the amniotic fluid clear? How many babies are expected? Or is there any other risk factors, like we have to go through the antenatal risk factors like oligohydramnios, abnormal anomaly scans, eclampsia, preterm deliveries, or if there is any intrapartum risk factors like abnormal CTGs, or is there any antepartum hemorrhage, cord prolapse. So we have to take into all the risk factors, and this risk factors has to be asked from the obstetricians once we enter the delivery room or the theater. So one qualified person who is skilled in performing positive pressure ventilation should be present for all the deliveries. And in the presence of any risk factors, 2 persons who are qualified in performing neonatal resuscitation should be present during the neonatal resuscitation. And a qualified team with full resuscitation skills, like you're getting umbilical vascular access, chest compression, intubation, should be present in the vicinity to help you. So NRP is all about teamwork, and teamwork and communication are key requisites for any neonatal resuscitation. And for the team briefing has to be done before any resuscitation, and for which we need to assess the perinatal risk factors. We need to identify a team leader who needs to delegate the tasks to various team members. And we need to identify who will document the events and determine what supplies and equipments that will be needed for the resuscitation. And we should also identify how to call for additional help. So once we're done with the team briefing, we should go ahead with the equipment check. And we should make sure throughout this process of preparation and during the process of resuscitation, aseptic precautions are correctly followed. So as we go through the equipment check, it's easier to go through based on what we do for the newborn during the resuscitation, like warmth. So for warmth, we need a preheated warmer, which should be switched on at least 15 to 20 minutes prior. We need at least 2 to 3 warm towels or blankets. For a preterm delivery, we would need a plastic wrap and a thermal mattress. And for clearing the airway, we need a bulb syringe or a mucus extractor. If it's a suction catheter, we need a 10 or a 12 French suction catheter, which is attached to a suction mounted, which is about 80 to 100 millimeters of mercury. And for auscultation, we need a stethoscope. For ventilation, we need the PPV device, which could be either a bag and mask or a T-piece resuscitator. And we also need appropriate size mask and a feeding tube. For oxygenation, we need equipment to give free flow oxygen, oxygen tubings. If possible, it's better to have a blender. We'll need a pulse oximeter to assess the oxygenation. And we also need a target oxygen saturation table as well in order to titrate the FiO2. With regard to intubation and medication, Dr. Uma Maheshwari will be dealing with these equipments. So this is the NRP algorithm that we need to follow during our resuscitation. So this is to highlight the importance of various sequential steps that we need to follow during the neonatal resuscitation. As we are all aware, in an adult, the most common cause of arrest is cardiac arrest, whereas in a neonate, it's always respiratory. And hence, we need to follow these sequences, especially positive pressure ventilation, before we do intubation and chest compression. So when we have a neonate who does not breathe or who is apneic at birth, we should go through initial steps first. Then, if the baby is not responding to the same, positive pressure ventilation, then assessment. If the baby is not responding, we have to make sure the ventilation that we are giving is effective by doing the ventilation corrective steps. And in spite of effective ventilation, if you're not able to achieve the desired response, then we have to go ahead with intubation and chest compression. Still no response, then we go ahead with medication. So at no point, we should not miss out on these sequential steps. And always positive pressure ventilation comes way ahead. So as a baby is born, so what is the assessment that needs to be done? We need to ask ourselves 3 questions. Is the baby term gestation or preterm gestation? Does the baby have a good muscle tone? Is the baby breathing or crying? If the answer is yes, then we go ahead with routine care, wherein the baby stays with the mother. We provide warmth, maintain the normal temperature, position the airway, clear the secretions only if needed, dry the baby, and do ongoing evaluation. So this should be the norm for all the deliveries wherein the baby cries at birth and the baby satisfies all the criteria in the assessment. So we provide warmth by placing the baby skin to skin with the mother and covering the baby with the warm blankets. And we don't have to do routine suctioning for all the babies. We need to clear the airway only if it is obstructing or there is any copious secretion. And we continue to do monitoring the vitals, especially the breathing, color, as well as the temperature. So one of the interventions that can go a long way in helping both the preterm and term babies at the time of birth is clamping of the cord. So as you can see in this diagram, a baby who is born with early cord clamping has a blood volume of around 70 to 80 ml per kilo. If you're able to delay the cord clamping by about 1 to 2 minutes, the blood volume goes up to nearly 100 ml per kilo. So how does it help? Especially in preterm neonates, it increases the circulating blood volume. It reduces the mortality as per Cochrane. It decreases the IVH in all grades. And these preterm babies have less needs for inotropes as well as less need for transfusion on the long term. And in term neonates, there is less iron deficiency anemia because this extra amount of blood gives a better iron storage for these babies, which can last even beyond 6 months. So as per the NRP guidelines, we have to delay cord clamping for longer than 30 seconds, but preferably it will be better to delay cord clamping by at least 1 to 2 minutes after birth. So what if the baby is not crying? So if the answer to any of these questions, like term gestation, good tone, or breathing or crying, if the baby is not crying, what should we do? We should perform initial steps, wherein we provide warmth, position the head and the neck, clear the secretions, dry the baby, and stimulate the baby. Let's see how we go about it. So how do we provide warmth? So if the baby is not breathing or crying, the cord is cut immediately and the baby is transferred to the warmer, and warmth is provided by placing the baby underneath the warmer. And positioning, baby has to be positioned in a neutral position or the sniffing position, and we should make sure that the baby is not either hyperextended or hyperflexed, which can block the airway. And once we have positioned, we need to clear the airway. Again, no routine suctioning for all the babies. We need to clear the airway if the baby is not breathing, if the baby has poor tone, if the airway is obstructed, or the baby would need a positive pressure ventilation. And suction has to be done first with the mouth, followed by the nose. As said earlier, we should use a suction catheter of 10 to 12 French, with a pressure of around 80 to 100 millimeters of mercury. And after we have suction, we should dry and do tactile stimulation, but it should be limited to drying, rubbing the back and the soles of the feet. There's no flicking of the soles, which is taken off from the last NRP. So this is the most controversial thing about meconium stained amniotic fluid. So what should we do about it? So we classify the babies born through meconium stained amniotic fluid as one, vigorous infants. Vigorous infants are the ones who are crying, who are breathing, who have a heart rate of more than 100, and who have a good tone. So these babies, they stay with the mother. We do oral and nasal suctioning if needed. With regard to non-vigorous infants, they're resuscitated in warmer like other babies. We do initial steps, including oral and nasal suction, wherein the routine intubation and endotracheal suctioning, which was recommended earlier, is no longer recommended, because the emphasis now, even for these babies who are born through meconium stained amniotic fluid, is ventilation. So we should not waste time in going ahead and doing an endotracheal suctioning. Rather, we should go ahead with positive pressure ventilation in these babies. So once we are done with the initial steps, we have to go ahead with initial assessment. We look at the baby's respiration, look whether the baby is breathing or baby is gasping. And we listen to the heart rate. Auscultation is one of the most sensitive ways of looking at the heart rate, wherein we auscultate for about 6 seconds, count the beats for 6 seconds and multiply by 10 in order to get the beats per minute. Palpation of umbilical cord can be done, but it is less sensitive compared to auscultation. So the latest in the latest NRP is to introduction of ECG electrodes in order to pick up the heart rate early, especially in preterm babies. Pulse oximeter again can be used to assess the heart rate, but it does take a few minutes time before we can assess the heart rate through a pulse oximeter. So now that the baby is breathing, so if the baby's breathing is labored or the baby is having persistent cyanosis, what should we do? So again, we go back to the basics, position the baby, clear the airway, and very important, we connect a saturation monitor and we give supplementary oxygen based on the saturation. And if the baby is having increased work of breathing, then we should consider CPAP. So oxygen administration, very important, the need for pulse oximeter in all the places of delivery. And we should connect the sensor to the right wrist because that measures the preductal saturation. And preductal saturation is measured because this is the same blood that perfuses the coronaries as well as the brain. So this graph shows the normal saturation of the term newborn without any risk factors who cries at birth. As you can see, a baby who at the time of birth has saturation of only around 70, and it gradually picks up to 85 to 95 by 10 minutes of age. And that is what is given in the target saturation. So if the baby whom we are resuscitating, if the baby saturation is around 70 to 75 at 3 minutes, there is no need to give oxygen. But at the same time, if the saturation is 95 at 3 minutes, probably we need to reduce the FiO2. And if the baby's saturation is 60 at 3 minutes, probably we need to increase the FiO2. So this gives us a guide to the saturation, to the FiO2 that needs to be administered to the babies during resuscitation. And we need to have this chart in the resuscitation trolley as well. So how do we titrate the oxygen that's been given to the baby? We can use the blender, wherein you can dial the FiO2 from 21 to 100%, or in places where there is no blender, we can use a Y connector. So Y connector, we have one flow meter which is connected to the air, the other flow meter which is connected to the oxygen. So based on the amount of gas that we mix, like 3+3 or a 4+2 or a 2+4 or 5+1, we can titrate the FiO2 that's being delivered to the baby. So for term neonates, resuscitation should always be started with 21% oxygen. We should never start resuscitation with 100% oxygen because there is increased mortality. And when all the babies for whom resuscitation was started when room air had a reduction in short-term mortality. And preterm neonates, we can start anywhere between 21 to 30%. Still, it's not very clear, but up to 30%, it's okay. So how do we give oxygen for these babies? There are two ways, either by free flow oxygen, wherein we hold the tube closer to the baby's nose, or by using a P-piece resuscitator. So this is a Y-piece connector that we use for transport of babies in our unit. So we can have, in the resuscitation trolley, we have an air cylinder and an oxygen cylinder, and we connect, which are connected by an Y-piece. As you can see here, we have a table which shows if you add 3+3, we get 6. Based on this, we titrate the FiO2 that is being delivered to the neonate. Now comes the most important step in neonatal resuscitation. So if the baby is not breathing or gasping, even after initial steps, and the heart rate is less than 100 per minute, then we need to go ahead doing a positive pressure ventilation. At the same time, we have to connect the saturation monitor and consider ECG monitoring as well. So
Someone
the
please
most
mute
important
it.
step, sorry, somebody.
Somebody is unmuted. Please kindly mute it. There are a lot of background disturbances are coming. Members, viewers, please.
So the most important step in NRP is effective positive pressure ventilation. So the indication for positive pressure ventilation is any baby who is apneic or gasping, or if the baby has a heart rate of less than 100, even after the initial steps, then we have to consider positive pressure ventilation. The equipments that can be used is self-inflating bag and mask. The main advantage of bag and mask is it's easily available, it's very economical, we don't need any compressed source of gas. But the disadvantage of self-inflating mask is we are not able to provide PEEP with the self-inflating mask, and we're not able to titrate or measure the amount of peak inspiratory pressure that we're delivering to the baby. So the alternative is TP's resuscitator. The advantage of TP's resuscitator is we are able to give PEEP and we're able to decide the PIP that needs to be delivered to the baby. But the disadvantage is it's expensive and we need a compressed source of gas to run the TP's resuscitator. So once we have decided that we're going to go ahead with positive pressure ventilation, we should call for help and connect the saturation probe and clear the airway. We should position ourselves at the head end and position the baby's head to the sniffing position. And we should choose the appropriate mask, which will cover both the mouth and the nose. So this is the correct mask, which covers both the mouth and the nose. It should not be small because it does not cover the mouth completely, or it should not be large. So it should be an appropriate mask. And once you have chosen the mask, we should place the mask on the face, starting from the chin and then going on to the bridge of the nose. And we should secure an airtight seal between the mask and the face with the thumb and the index finger encircling the rim and the other 3 fingers on the mandible to just pull the jaw. When we are using a round mask like this, holding the stem and giving a slight downward pressure is more than enough to achieve an airtight seal, because that is very much important to deliver effective positive pressure ventilation. So once we have achieved a good seal, we have to start ventilation. The ventilation rate is 40 to 60 per minute in the sequence of breathe, 2, 3, wherein during breathe we squeeze and during do 3 we release. And the peak inflation pressure that can be delivered when we are using a TP's resuscitator is around 20. And the inspiratory time that we can use while we're using a TP's resuscitator should be less than 1 second. So how do we assess our positive pressure ventilation? What is the indicator for an effective PPV? So we have been telling again and again, it's not just positive pressure ventilation. It has to be an effective positive pressure ventilation. The most important, the best indicator is the rising heart rate. So we have started PPV. We assess the heart rate after 15 seconds of PPV. If the heart rate is increasing, we know it is effective. So we continue PPV for another 15 seconds. And then we go ahead with assessment again after a total of 30 seconds. What if the heart rate is not increasing after 15 seconds of PPV? Probably the PPV, then we have to look at the chest movement. If the chest is moving, if chest is moving, yes, your PPV is effective. So we continue PPV and reassess heart rate after 15 seconds. But the heart rate is not increasing and chest is also not moving, then probably we have to think that our PPV is not effective and we have to go ahead with a ventilatory corrective steps or MR SOPA. So MR SOPA stands for adjusting the mask. So we adjust the mask again to ensure a good seal on the baby's face. And we reposition the airway by adjusting the head to the sniffing position. So after we do these things, adjusting the mask and repositioning, we attempt to ventilate again and reassess the chest movement. If there is good chest movement, we continue the same for another 30 seconds and do the reassessment. But if still there is no chest movement, we go ahead with the next 2 steps, which is suctioning and opening the mouth. So we suction the mouth and the nose for secretions. We open the mouth slightly and move the jaw forward and keep ventilating with the mouth open. So again, we try PPV and reassess the chest movement. Chest movement is there. We continue PPV for 30 seconds. No chest movement, then probably next step would be to increase the pressure If you're on a T-piece resuscitator, we can go up to 30 or 35. But if you're on a bag and mask, probably you can increase the pressure that is being by squeezing hard on the bag and mask. But still, if you're not able to achieve a good chest movement, probably we should consider an alternative airway like endotracheal intubation or laryngeal mask airway. So we should always remember MR SOPA has to be considered before we go ahead with the next step of chest compression. So the take-home messages is anticipation and adequate preparation is the key for any neonatal resuscitation. Delayed cord clamping is a simple intervention that can help both preterm and term babies, and we should provide skin-to-skin care for all the babies. The most important step in NRP is effective positive pressure ventilation, not just positive pressure ventilation, but effective positive pressure ventilation. Endotracheal suctioning is not indicated in non-vigorous meconips and amniotic fluid babies. And MR SOPA should be done in cases of ineffective PPV. And with regard to oxygen, resuscitation should begin in 21% oxygen. And based on the baby's saturation, it should be titrated further, either with a blender or a Y-piece connector. Thank you.
Thank you, Balakrishnan, for your wonderful presentation on essential NRP. I don't think there is any questions in the chat box. I request all the participants to put their queries in the chat box. Now they are busy in entering their name and register number for the points. So all the participants kindly put their questions in the chat box. Now we'll go on to the next topic, that is Dr. C. Vinod from Madurai. He is going to present a video demonstration on basic NRP. Over to Dr. Vinod. Dr. Vinod?
Yeah, yes, sir. Can you hear me, sir?
Yeah, you are audible.
Yeah, thank you so much, IAP team, for providing me this opportunity. It's my pleasure to be here with all the stalwarts of neonatology. Thank you so much. So far, Dr. Balakrishnan has clearly and beautifully explained the steps that are involved in basic resuscitation, starting from preparation till providing positive pressure ventilation. And in the next 20 minutes, though it's hard, I'm going to demonstrate with videos the steps that are involved in providing resuscitatory measures from preparation till positive pressure ventilation. So first thing, a 25-year-old primary gravida mother, it's a term gestation, she has been admitted in active labor. So the pediatrician arrives here for resuscitation or for receiving the baby. So how to proceed with this? So resuscitation does not start with the time when we receive the baby. So we need to be prepared for that. Good evening, everybody. In this video, we are going to demonstrate the pre-resuscitation preparation before receiving the baby in the delivery room. First thing comes is the proper aseptic precautions. That is proper hand washing based on the recommendation, which is followed by wearing sterile glove, apron, mask, cap, etc. And after that, we should anticipate the risk factors based on the 4 questions we ask. One is the gestation rate, whether it's a term or a preterm baby, whether the likelihood is clear.
Dr. Vinod, is it possible to increase the volume of your resuscitation?
Risk factors in mother or in the baby.
Pardon, sir?
So with this fact,
the volume is too low. Can you increase it?
Yeah, 1 minute, sir.
Can I suggest something here, Dr. Vinod? Can you move to the top? No, Dr. Vinod's screen is there. No, on.
Yes, sir.
What you do is, I will go there to the remote control there. No, when you on top of the screen you are having on green color.
Yes, sir. Yes, sir.
You go to the right extreme. Is there an option called more?
Yes, sir.
In that you have clicked the share your video, share your audio. Is it ticked?
Yes, sir. Share computer sound.
No, yeah, computer one share video sound is there. In that one of the options is share video sound.
Okay. So share computer sound is there, sir.
Okay, yeah. And okay, and then you come to the microphone.
Okay.
In that you can choose stereo mix, but if you're not going to speak, then you can put that, then you will get the audio output from this thing directly. If you also have to speak, then it will be same as system. If you click that microphone, the microphone on your, if you go to the screen, there's a microphone. Just click that arrow, you'll get a lot of options. In that, select a microphone. In that, there is headset, your stereo mix.
In that more options I need to see, sir.
Yeah, just in the microphone, there's an arrow near to the microphone.
There is nothing stated as microphones.
No, the one, there will be a mic, like mic and the video on top of the screen. On the top of your screen, there will be a green color thing, in that on your extreme left.
Okay.
Or he can talk and
yes, sir. In microphone.
Just click that arrow.
Okay.
In that, you just see if stereo mix is there. Stereo mix.
Yes, sir. Stereo mix is there.
Yeah, probably that will be taking only audio from the computer.
Audio seems to be okay, Vinod.
Or you just talk through it, Dr. Vinod. If you can talk through it, also it'll be fine.
Your audio is clear.
Just, can we check this option, sir? So it will work, I think.
If I select stereo mix, can I talk from here, sir?
Yeah. You mute it, and then you can talk from here.
No. If you're putting a stereo, if you want to talk, you can log into another phone, and you can talk.
Sir, Ilana, you just try it now because we are falling behind. Can we just try it again?
You go back and try again, Vinod. Your audio is fine.
Yes, sir. Good evening, everybody. In this video, we are going to demonstrate the pre-resuscitation preparation before receiving the baby in the delivery room. First thing comes is the proper aseptic precautions. That is proper hand washing based on the recommendation, which is followed by wearing sterile glove, apron, mask, cap, etc. And after that, we should anticipate the risk factors based on the 4 questions we ask. One is the gestation age, whether it's a term or a preterm baby, whether the likelihood is clear, how many babies we are expecting to receive, and last one is the associated risk factors in mother or in the baby. So with this background, we need to assign a proper team. Team briefing is more important before receiving. So we should assign the leader and also the supporting person to help in resuscitation. So with this, let us move on to equipment check now. So we assessed the risk factors, anticipated the risk involved. So we have started on team briefing. We have briefed the team, and now we move on to equipment check. Coming to equipment check. So in this, we are supposed to check for the availability of all the equipments that are needed for resuscitation. Not only that, we need to ensure that they are functioning well. So going in a systematic way, first of all, we are supposed to look for the temperature maintenance. So for this, we need to have a radiant warmer, which has to be switched on at least 20 minutes prior to receiving the baby. We should have 2 pre-warmed towels. There is towel that has to be pre-warmed by placing under the radiant warmer. Then having plastic wraps, that is for receiving preterm babies for less than 32 weeks of gestation age. Then coming to airway, have a shoulder roll, have a bulb syringe, and having a proper suction apparatus, suction tubings, and also suction catheters. At least 12 French and 14 French catheters should be available. Then we have the cord clamp. We have sterile blade or sterile scissor to cut the cord. We have the stethoscope to assess the heart rate after initial assessment. Then coming to oxygenation, we need to have the central oxygen supply with the blender oxygen tubings. To assess the oxygenation, we need to have a pulse oximeter and pulse oximeter probe. ECG monitor should also be available, and for that we have the ECG leads. Coming to providing positive pressure ventilation, we need to have the self-inflating bag of appropriate size and volume. We need to have 2 sizes of mask, one for preterm and another one for term babies. So more important thing is we need to check the functionality of the self-inflating bag beforehand. This is very important. Okay, so we have the reservoir in place. So if you are going to provide positive pressure ventilation for more than 2 minutes, we are supposed to decompress the stomach. For this, we need a orogastric tube of 8 French and a 20 cc syringe. So coming to intubation, we need to have laryngoscope blade of sizes 0 and 1. 0 is desirable. More important thing is we need to see whether it is functioning well. So we need to have extra set of batteries. Still it is optional. Then ET tubes of sizes 2.5, 3 and 3.5. So we need to have adhesive tapes to fix the ET tube. Then coming to medications, we need to have adrenaline, normal saline. We need to have appropriate size syringes like 1 ml, 10 ml, 2 ml, 5 ml syringes. So for establishing vascular access, we need an umbilical catheter, a 3-way adapter. To cut the adhesive tapes, we need to have scissor. And this is TP resuscitator we can use instead of self-inflating bag. So adhesive tapes are also available. So we need to have a clock to assess the timing, and also we need to document the interventions. So all these things to be carried out, and all these things have to be checked before receiving the baby. So once equipment check is over, we need to be ready to receive the baby. So here comes another scenario. It's a healthy woman, 26-year-old, 39 weeks of gestational age, that is a term neonate, comes to the hospital in labor. Her pregnancy has been uncomplicated, single baby, membrane just got ruptured after arrival to the hospital, and the liquor is clear. So all the 4 questions are answered. So this looks like an uncomplicated delivery, and the mother is about to deliver. So how to proceed with that? So assuming this baby is delivered now by normal vaginal delivery without complications, how we are supposed to proceed? So now we are going to see how we are going to manage a baby that has been born normally. So in this normal delivery, assuming this baby has been born via normal vaginal delivery, so first thing we need to ask should be whether the baby is having proper respiratory effort, and also whether the baby is crying well and the tone is normal. If all these things are good, the baby is doing well, then immediately we need to place the baby over the mother's abdomen, providing a proper skin-to-skin contact to maintain the temperature normally. So look into the airway. Only if there are secretions in the airway, we are supposed to go for suctioning, either bulb syringe or central suction with the suction catheter. So after that, dry the baby over the mother's abdomen, remove the wet linen and replace it with the warm towel lining. So these things will be done with intact cord. So wait for 60 seconds, let the baby be on mother's abdomen, providing a skin-to-skin contact, and after 60 seconds, umbilical cord should be clamped and cut. Okay, so after that, baby has to be started on breastfeeding. So this is how we are supposed to manage a baby which is born normally. And here itself, we need to evaluate the baby for proper respiratory effort, tone, heart rate, color, as well as temperature. So this is for a baby which has a normal transition. If there is a delayed or abnormal transition, so how we are supposed to proceed? This baby has been just delivered. This baby doesn't have a good respiratory effort. Baby is apneic, no cry, and the baby is floppy. So the cord has to be clamped and cut immediately, and the baby has to be brought to the radiant warmer. Baby has to be kept in a flat position with the whole body exposing towards the radiant warmer. So immediately after placing the baby has to be positioned. The airway has to be patterned. So place a shoulder roll. Keep the baby's neck in a slightly extended position. Look into the airway. Only if there are secretions that obstruct the airway, you are supposed to go for suctioning, or if there is no need to go for routine suctioning. Suction catheter, please, sister. So suctioning has to be done first in the mouth and then into the nose. So after clearing the airway, the baby has to be positioned well. So baby has to be dried with the towel, and the wet towel has to be removed immediately, which is replaced by a warm towel. So the baby has to be repositioned now, and after this baby has to be given tactile stimulation by rubbing over the back as well as the extremities. All these things have to be done within 30 seconds from the time of delivery. So after these initial steps are over, we need to check for the response. That is by checking the heart rate and also the respiratory effort. So heart rate at this stage has to be evaluated by using a stethoscope. Stethoscope, please, sister. So count the heart rate for 6 seconds and then multiply it by 10. So it has to be auscultated over the left side of the anterior chest wall for 6 seconds. And when you multiply with 10, you will get the heart rate for 1 minute. So this is how we are supposed to evaluate the response after the initial steps. So the baby has been assessed after the initial steps, that heart rate as well as the respiratory efforts are being counted. So the same thing has been given as a scenario here. Since the baby had a delayed transition, initial steps were performed and the baby was assessed for response. So how to proceed further? So here, after the assessment, we find that the heart rate is more than 100 and the baby is having normal spontaneous respiration, but the baby is found to have cyanosis. So how central cyanosis, how to proceed with that? After providing the initial steps, we need to assess the baby. So after the initial assessment, we need to look into the heart rate as well as the respiratory effort. So here, the baby's heart rate is more than 100 and the baby is having good respiratory effort, but the baby has central cyanosis. Central cyanosis may be normal up to a certain point of time in any baby, provided it falls within the target oxygen saturation. So here we are supposed to monitor the target oxygen saturation, preductal oxygen saturation. Please place the probe in the right hand, sister. So monitor the saturation and compare with the target saturation. If it falls below the target for that age, we are supposed to start on free flow oxygen, provided the baby has good respiratory effort. Oxygen, please. So the oxygen has to be placed near the baby's nose and see that the baby is breathing well. So titrate the oxygen based on the target saturation for that age. If the baby has labored breathing and the heart rate is more than 100, then it is time to start on CPAP, that is delivery room CPAP concept. TPs, please. So this has to be given through TPs resuscitator. So what we are supposed to deliver has to be preset here and it has to be delivered through a snugly fitting mask. Gently place it over the baby's nose and mouth, covering both the nose and mouth, and provide PEEP to the baby. So with this, we need to shift the baby to an ICU or post-resuscitation care. So on the other hand, after the initial steps, if on assessment, if the baby is found to be apneic and the baby's heart rate is less than 100, so how we are supposed to proceed? So the initial steps are over and the assessment has been made. Now after assessment, the heart rate is found to be less than 100 and the baby is apneic with no respiratory effort at all. So this is the ideal time to start on positive pressure ventilation. So usually we start positive pressure ventilation with self-inflating bag with appropriate size mask. So mask has to be placed first over the chin and ensure that both mouth and nose are covered. So with this, we need to start on positive pressure ventilation. Keep the thumb as well as the index finger and hold the mask. The other 3 fingers should be placed over the mandible. So when we start on positive pressure ventilation, it's ideally to be started on pulse oximeter monitoring. Place the probe system on the right hand. So if you have the facility of ECG monitoring, the leads also have to be connected. So regarding oxygenation, it is desirable to start at 21% FiO2 when we deal with term babies. If it is less than 35 weaker, then we are justified in starting somewhere between 21 to 30%. So we need to give in the sequence of breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3. So you need to give in this sequence and look for the chest rise. So we are starting on positive pressure ventilation. How to look for the response? Okay. So first give 15 inflations. Breathe 2, 3, breathe 2, 3, and look for the rise in heart rate. So the best indicator that we are properly ventilating the lung is the rise in heart rate. So if there is rise in heart rate, then continue for another 15 seconds, and after the end of 30 seconds, we need to reassess. If there is no rise in heart rate, then look for chest rise. So if there is chest rise, then also we are adequately ventilating. So we can continue for another 15 seconds, and at the end of 30 seconds, we need to reassess. If both heart rate is not rising as well as the chest is not rising, then we are supposed to go for ventilation correction steps. So that goes by the name MR SOPA. If in such a case, reposition the baby and give inflation. If there is no chest rise again, then look into the airway. If there are secretions, go for suction. Suction 2, please. Clear the secretion.
4 minutes here.
Keep the mouth open and ventilate. Even then, if there is no chest rise, you need to increase the pressure and look for chest rise. And even then, if you are not getting any chest rise, then it's time to go for alternate airways, that is intubation. During this process, if you are getting chest rise at any particular point of time, give positive pressure ventilation for 30 seconds from that point where we get an adequate chest rise. That is effective positive pressure ventilation. After that, we need to look for the response. Okay. So the alternate way, another way of giving positive pressure ventilation is TP resuscitator. So the same way, you need to keep the mask, and positive pressure ventilation can be given by occluding the valve here. So the desired PIP can be set here and it can be delivered to the baby. So give effective positive pressure ventilation for 30 seconds and then reassess. The reassessment means again look for the heart rate and also respiratory effort in the baby. So, few words about TP resuscitator.
So just I wanted to show TP resuscitator. It's an alternate way of giving positive pressure ventilation. So this is the gas inlet where we are supposed to give the inlet of gas. We can give a flow of up to 5 to 15 liters per minute. So this is the outlet, and this tubing has to be connected, and the mask has to be placed over the baby's mouth and nose. So this is the outlet valve. This one is the inlet for the gas. Okay, so this is the maximum pressure limit beyond which we cannot deliver, and this is the port to adjust peak inspiratory pressure. PIP. That's what we are supposed to deliver. So once we close, once we close it over the baby's mouth and nose, when it snugly fits, the amount of PEEP that has been delivered will be displayed here. The PEEP can be adjusted by rotating the valve over here. So this is how a TP resuscitator works. So be it TPs or self-inflating bag, whenever we give positive pressure ventilation, if you are giving positive pressure ventilation for more than 2 minutes, then it is desirable to decompress the stomach using a nasogastric tube and a 20 ml syringe.
Another 2 minutes, Vinod.
Yes, sir. My presentation is over, sir. I have almost finished the demonstration from preparation till completing positive pressure ventilation and reassessment, sir.